A very good morning to one and all assembled here. And as for today's clinical meeting, Department of Obstetrics Gynecology, we have two papers. One is gestational motherhood by me, and the next one is by Dr. Kanmani on the interesting cases in urogynecology. So we'll be wondering what is gestational motherhood. This is one of the innovative techniques which has come up in the field of obstetrics and gynecology. After IVF session, it has taken a long way, and now a new innovation in the field of obstetrics and gynecology has come. So it is a future for infertility. So the motherhood, when you see, I can imagine no heroism greater than motherhood. It is a real word. Nothing is equaling to the motherhood, the experience of a person, and we say in Tamil, Taima is the completeness of any woman. That's why it is done. And we have many reasons for the infertility, male factor, female factors, but there is something called absolute uterine factor which is causing infertility. So there are when there is presence of uterus or absence of uterus, there are some syndromes. We have Mayer-Rokitansky-Kuznets-Causer syndrome, which is also common, and complete androgen insensitivity syndrome, which are all, there are no uterus is there, or it is very much underdeveloped. The lady cannot conceive. But in certain situations where the hysterectomy is done for placenta accreta or so many other reasons, postpartum hemorrhage, she has lost a baby also. So she is very young. In future, she likes to have another baby. So we have an option. The new tool is there for us. And in some benign conditions where she is not able to achieve pregnancy, this will be useful. So we have new innovations in the form of, we'll see what is the new tool available. This is underdeveloped uterus in the case of the syndromes. And why this focus on these population alone? Because they constitute a good amount of number. So 1 in every 5,000 female babies born will have that syndrome. So which is absent or underdeveloped uterus. So it constitutes a good number. So these mothers will be benefited by that. So this we have that in the form of uterine transplantation. We have heard about renal transplant, cardiac and liver, which our colleagues are also doing. We are an institution approved for the transplants. So I thought this will be an ideal platform to present the innovation recently come. We had animal experiments and the human experiments way back from the 2000, and it has reached up from 2010 onwards, taken a momentum in the human beings. And the first one is 2012, it has come in Sweden, and subsequently India has done a good outcome with a live birth in 2017, and still it is going on. It is 2020, this uterine transplantation has been accepted as the treatment modality by the forums, and we have 2022, there is a registry which has come, which is there. So this is just a simple explanation. There is a donor and a recipient. The recipient is a person without a uterine factor, absolute uterine factor infertility. The couple should have an understanding, a well-established partnership, and before conception, before entering into this program, the gametes are taken and you preserve the embryo, and then she enters into the program. And then the uterus transplantation done. We'll wait for the outcome, whether there is a rejection or any complication, and then wait for some time. If everything is fine, then go ahead with the pregnancy and deliver the baby. If there are many complications as per the general population, then after this, she can have 1 or 2 pregnancies with that transplanted uterus. Finally, that uterus is taken out because with the immunosuppression has to be given a long time. When you look at the donor and the selection and the recipient selection, there are some criteria there. And we have nowadays the donor, it's a live donor or deceased donor or the cadaver also there. But we have the donor selection, it will be younger than the 60 years, just entered into menopause, healthy life, she would have had any good fertility issues, and then presence of no infection or any other comorbidities. And the recipient also less than 38 years, and the absolute partnership with the husband, that's a stable partnership should be there. and their attitude, and BMI and infections are also important to know about it. And there is, as I said, living donor and the deceased donor. Living donor, we have we have a good medical assessment can be done. We can schedule it properly. Only thing is, in the lifetime, she may have some comorbidities on account of that. But a deceased donor, the medical records, we need to look into it and then see how the scheduling is difficult because of the availability. But sometimes the elaborate dissection can be done. So, what are the real steps following that in uterine transplantation? You do harvest the uterus from the donor, and it has to be vascular anastomosis has to be done under fixation of the transplanted uterus. In the meantime, during the procedure, you have a bench surgery where you will really take care of the ischemia. The transplant people, colleagues will be really knowing what is the importance of that period, which is going to give the best result. Subsequently, immunosuppression, and you have to see whether even if there is a mild rejection, that has to be tackled. So we have the procurement of the uterus. When we take the uterus, the pedicles, the vascular pedicles are taken 9 to 11 centimeters. Even then, suppose you take a uterine artery, up to internal iliac artery, anterior division, it will be taken, and the veins also taken. Nowadays, the utero-ovarian vascular complex is taken, very important step, so that can be taken. So that will be utilized, and then afterwards you take it to the table and prepare it. Vascularization has to be checked, canalization, and once that is done in the recipient, these arteries are connected anastomosed to the internal iliac artery to the external iliac artery, and the veins are into the external iliac vein. So this will establish on both sides, and right and left side, the vascular anastomosis will be done, so that it will be the perfusion of the uterus will be taken care, which will depend on the further outcomes. So this is a diagrammatic representation. In India, the Shailesh Puttambaker from Pune has done the first uterine transplant, and even he has proven, and it has been worldwide recognized, the uterus can survive with one uterine artery and one ovarian vein. So that ovarian vein has been taken, given importance, that harvesting and this thing. Uterine vein has been taken out because there is a difficulty in our practical issues are there. So they are very comfortable with the ovarian vein. And take a large fold of the uterovesical fold of peritoneum, which can be utilized further. And the graft preparation, you cannulate every single branch and then see the perfusion, and that is very important. It will take at least 30 to 45 minutes. Before doing the procedure, DJ stunting for prophylactic injury, to prevention of the injury to the ureter, and we can omental patching can be done around the ureter. Suppose devascularization takes place, with no problem should come to the ureter, which is a long-term morbidity for the donor. And then fix the transplanted uterus into the vagina has to be there, proper vagina for the recipient, at least 7 centimeters should be there. So we anastomosis. The sutures used for this anastomosis for the vascular will be very fine sutures, but here we can use the long term or slow dissolving sutures. And round ligament, uterosacral, all those fixing structures can be the supporting structure. We have taken a very large fold of UV fold of peritoneum, which can be covered well, so that the graft area will be taken care. And once that there is a time interval between the uterine transplantation and the pregnancy. Once they are pregnant, we will not allow them to go for a spontaneous labor. So after the transplantation, what are we going to do? She'll be on immunosuppression, as you all very know, and actually the embryo transfer to be done only after 3 to 12 months. We shall be observed in the post-operative period. Every day, first day and the 5th day, the Doppler will be done uterine artery, whether the perfusion is fine, and then subsequently in the postpartum period also it will be done. Pregnancy can be monitored once the embryo transfer is done. During the pregnancy also, the Dopplers are done in the when 16 weeks, 24 weeks, so that we are able to say. Even the biopsy of this, there is a provision of the cervix biopsy even in pregnancy or before pregnancy, which will tell you early detection of the rejection. The mild rejection of the graft can be identified using the cervix biopsy, which is amenable. The subsequent to the delivery, it is ideal to take off the uterus, the grafted uterus, either postpartum soon after section or 3 weeks, 8 weeks like that. In 8 weeks means suppose we can do it with the laparoscopy. And to minimize the long-term effects of the the patient need not be on the immunosuppression once you take off the uterus. The hysterectomy is to be performed. And definitely they will be followed for the children, the partner of the recipient, and all health problems we have to be monitored. And this is a elaborate the things which are used for the immunosuppression. I think it will be a thing for everybody. During pregnancy, we will avoid which are drugs which are causing teratogenic or anything. So we have the steroids can be easily given B drug, and other C drugs and D drugs are also used. So we will decide which one will be used during the course of pregnancy, and for the maintenance what is the drug which will be used. So that is how the pregnancy related group of the drugs taken care. So the success of the transplant is assessed through the 3 stages. The first 3 months focus on the graft viability, followed by 6 months to 1 year for monitoring the uterine function. Usually after the second month of transplant, she is supposed to get a menstrual cycle. So that is an indication that graft is working well. Only after this period can the recipient attempt on the conception. So roughly this is the timeline, the process which we have seen already, the initial from the medical evaluation, and you have the create embryos, and then 6 months later the transplant is done. Then you have the pregnancy going for 9 months, and subsequently later on the hysterectomy. So they have even told this is a flow diagram, same. She can have 1 delivery, 2 deliveries, even 3 deliveries up to 5 years, depending upon the desire. But once that function transplant is working well, but imagine, you have to remember on all those years she will be on immunosuppression. You have to give away the balance whether she is allowed like that. So there are definitely risks to the women, preoperative, intraoperative, and postoperative. The counseling in the preoperative really extensive for donor and the recipient. It is very well designed, and you have to follow certain criteria. Intraoperative, it's definitely prolonged. Nowadays, the donor harvesting uterus is done by laparoscopy and robotic surgery, which has come recently. So that is the anesthesia can be cut down if it is possible. But depending upon the anesthesia longer period or the comorbidities, you can have the postoperative complications. Sometimes the bleeding can be one of the things, and cold ischemia of the uterus to preserve it by chilling. That is the number one which has to be I think the transplant people, everybody is well versed with all these things, and the meticulous thing about the vascular anastomosis which will heal the uterine perfusion. And postoperatively, definitely we are all aware of the immediate and later postoperative comorbidity or complications which can be there, and per se the pregnancy complications like PIH and other things also there which will be tackled. So but main complication during pregnancy is the graft rejection and dysfunction. But they have even compared that live birth rate for the embryo transfer is for cleavage stage embryos it is 27.8. It's a good number, and 40% for the blastocysts. I think IVF Dr. Lakshmi and all will appreciate how much there it is very important. Overall birth rate is around 35.8%. These are the complications like a graft related, recipient related, pregnancy related, and psychological disturbances each one undergoes, including the husband of the recipient. So that is taken care. And morbidity due to the injury to the neighboring structures in the name of ureter, bladder, vagina, and sepsis if it is happening. And the recipient also is the same thing, but the graft rejection. So we have a small word about the rejection. It is hyperacute rejection if it occurs within minutes to hours, acute rejection if it is days to months, and chronic rejection from day to 1 to slow process. In uterine transplantation, we are expecting the outcome only after nearly 18 months. So we have to wait till that time. Then only it is a successful one. So the indicators we are all know, it's Doppler uterine flow and the CD4 count. And the one more thing is the cervical and endometrial biopsy, which is easily amenable. This is a diagram showing on the left side you have the signature histopathological things in case of liver, heart, kidney and cardiac, which are commonly done. So we have cervical biopsy with the inflammatory cells which can mark and say mild, moderate and severe. So we have a early indication of the rejection of the graft. Definitely ethical considerations come into play. Recently we have organized an organ donation program as well. We are also doing many of the cadaver transplant, everything. So it is uterus transplantation is a fundamentally different from most other types of transplantation because it not neither a life-saving nor life-prolonging procedure, seen as a quality of life-enhancing transplantation. The principle of weighing the risks against the benefits of this undertaking is even more delicate. So it is the one aspect and an innovative procedure in the form of treating infertility. There are definitely Montreal criteria it was established. You have to follow for all the 4 people. So this is a paper, they have scientific impact paper. It is from the Royal College of Obstetrics and Gynecology. They have impact paper, it has come out in 2021. Usually we follow NICE or OCOG guideline. So in 21 only it has come. And how do you measure your success? Definitely the last will be the live birth. But before that, the donor outcome, recipient outcome, and the graft outcome, maternal complications or morbidities, and we are also following the baby which we are going to deliver. Is it all right? Is there anything extra morbidity or malformations can be there? So long-term health outcomes look into all these 4 people, including the recipient partner. So we have something called adoption and surrogacy, which are available for the people who don't have the cannot. But the joy of motherhood involves getting pregnant, feeling the child grow in your womb, feeling the fetal movements, and those tender conversations with the unborn child, the Braxton Hicks contraction, the labor pain, and the joy of here. The labor pain is not there, but at least the rest of the things she can have. So this is not possible in case of surrogacy. So we can consider uterine transplant a risk to life or chance to life. It is gestational motherhood, we call it. That's why the title. It's a medical, surgical and obstetric innovation persists to allow the ongoing success of the uterine transplantation. We have technology advanced and the skills of the people developing towards that. So uterine transplant is an answer to the complete motherhood. When we look at adoption, legal. When you look at surrogacy, it is a genetic motherhood. When you look at uterine transplant, it's a legal, genetic and gestational motherhood, a wholesome experience. That's why we are here. These are the things, just for the completion sake, even that what to be set for setting an IVF lab, we have some criteria. Similarly, for uterine transplantation, it will be there are some things which can be available. Maybe in long-term vision, our institution can be one like that. Yes, sir. In 2012, it is the first uterine transplantation a success childbirth. But in India, in Pune, we have 2017, and the 26-year-old patient had been given the donor was her mother, and the outcome was good, live birth. There are some developments going on in this field also, robotics and non-invasive rejection diagnosis, an increase of the donor pool. The bioengineered uterus, that is where the immunosuppression need not be there. So that kind of development is going to happen. And we always look at the long term, either down the lane, 10 years, 15 years and 20 years. And what is the attitude of the people accepting this novel treatment? There is a paper which is telling that the people are really for it. They say the results of this survey indicate that the uterus transplantation is desired by most women who would benefit from the procedure, including those with the either Morris syndrome or absolute uterine factor infertility. So it's one of the things. Recently, I had a chance to see 2 days ago, this is an article from the JAMA, released on August 15th. It's a paper from the US. The conclusions are, uterus transplant was technically feasible and was associated with a high live birth rate following successful graft survival. But adverse events were common, with medical and surgical risks affecting recipients as well as donors. Congenital abnormalities and development delays have not occurred till now. Maybe the number is less, but whatever it is, that so far it is like that. And the same article issue, you have an editorial which is describing about the uterus transplant, the frontier of innovative fertility treatment. So they say the IVF efficiency and effectiveness have improved over the years, and ideally the uterus transplant also will follow a similar trajectory. So it will take some time. Initially everyone was scared about the IVF. Now it's taken a long, the saying developmentally so high, and you have enough and more research papers. In time, the uterus transplant will likely mirror the experience of other solid organ transplants with improved outcomes and decreased great loss or morbidity. So it provides, in addition to that, uterus transplant provides a unique opportunity to understand uterine biology, the regenerative behavior of the endometrium, and the physiology of pregnancy and labor to enhance the understanding of the immune system function. So you have both sides to be, the researchers will be going on to see whether everything is in place and the mobility will be reduced. Regarding the uterine transplant, which is an innovative technique, and in India also we have, two-digit number going on like that. They have done a successful live birth rate. I thought this will be a forum to share that innovation with you all. Thank you so much. This is the graphic animation to understand how is the transplant taking place. The uterine vascular anastomosis and the fixing of the uterus. So that's it. Thank you so much.
Thank you, madam. This transplant looks totally different. Now Dr. Jaibal is sitting in front thinking what this transplant is. Okay, so...
Any comments from him?
No, he'll comment shortly. So what is the endometrial physiology that will get affected if you get a donor of, for example, 59 years? Because you are told...
actually, see,
60 years.
Yeah, but it will be they will prime everything. First, they see the perfusion and everything. Once she starts menstruating, I said roughly around 2 months later, she will start menstruating. That's a good sign that the graft is taking up. And once that is there, they always prime the uterus. So that usually will be a good job. Will not be a problem. Dr. Lakshmi?
HRT for embryo transfer, we give estrogens and prime the uterus. And once the intervention is good, we can add progesterone and do the embryo transfer. It will be something like that.
And enhancing techniques also available like PRP infusion. So many other things are there. The gametes are from already taken and the embryos are developed and kept in the freeze. So you.
It's not about the embryo side, it's about the
endometrium receptivity. Once the uterus is vascular perfusion graft is taken, then it starts menstruating. That itself shows it's a good functioning uterus. And they will also additionally prime the endometrium implant. But only thing, as you are mentioning, if there is repeated implantation failures, that time they go for graft hysterectomy. They will not continue to proceed with the baby pregnancy.
So you do graft hysterectomy after childbirth?
Yes, it is. Initially, they thought soon after the baby delivery it can be done. Now the people little greedy, where they want to have one more pregnancy up to 5 years, so that can be done. They have proven like that. But later, at least 6 to 8 weeks later, you can do the hysterectomy, which can be done as a laparoscopic surgery. But she has to undergo 3 surgeries. Recipient.
With published abortions and all those other problems are completely some more.
Yeah.
Any questions? So I understand endometrial carcinoma and cervical carcinoma are very commonest. One among the commonest kind of female. I understand that endometrial biopsies and cervical biopsies would have been done prior to the...
Yes, the complete evaluation of the donor, it includes everything. The selection criteria is very stringent, then only it has been taken. And usually the mother and the daughter, that is a kind of thing sharing, and it has been done. But it needs a lot of work. It is not just like that simply, because you have to wait for the result or the outcome at the end of 18 months, the live birth. So we are aiming for that.
Yes, sir. So when you transplant, they remove the graft after the work is over. Come here.
It's a very job specific transplant, so it's a job design there.
Yeah.
So, like to add a comment on this, more than the technical aspects, the crux lies in the maintaining immunosuppression during pregnancy and the childbirth period. That's where the more data is yet to evolve. And, the teratogenic potential of all these bits at this level of pregnancy is not is yet to be completely understood.
That's a very important. That's why the graft rejection is one of the important complication and in spite of immunosuppression.
What is the rough number till now, madam, in the literature?
US paper one has given 20 and India some around it has crossed single digit. It has crossed.
Yeah. So very nice talk, madam.
Thank you.
I'd like to thank management and everyone assembled here for giving this opportunity. So, on behalf of our Department of GA Surgery, HPB Surgery and Liver Transplantation, I'll be showing 2 videos of advanced laparoscopic surgeries of liver and pancreatic surgeries, and we'll be discussing on it. The first case is a 71-year-old male who had hypertension and diabetes for 15 years duration, who presented to us with a loss of appetite for 4 months, and he lost around 5 kg in that period time. The examination was largely unremarkable. He had a decent performance status. The blood investigations sort of raised CA 19.9 and rest of the investigations were within acceptable limit. Albumin was slightly lower, which was around 3.2. He was initially evaluated with ultrasound abdomen, which showed a lesion of size around 6.5 centimeters in the left lobe of liver. Subsequently, CECT abdomen was done. This is the first image, shows the biliary dilatation on the left lobe of the liver, and the second image shows the tumor in the left lobe. The tumor appears as hypodense, which indicates it's mostly an adenocarcinoma variant and not a hepatocellular carcinoma variant. And the tumor was also encasing the left portal vein, and it reflects in the form of atrophy of the left lobe as compared to the right lobe. So this is the video of the surgery. So after the port placements, the abdomen was inspected for any metastasis, and once it was clear that there are no metastasis, the first step is to mobilize the left lobe of the liver. This is a tumor which appears as the greyish white on the undersurface of the left lobe of the tumor. The tumor was involving the segments 2, 3 and 4B of the liver, and the size of the tumor was around 7.5 centimeters. Once the left lobe of the liver was mobilized, the next step is to dissect the hilum and take inflow control. Here, the left hepatic artery is isolated and the tissues around the left hepatic artery is being dissected. Once the left hepatic artery is completely isolated, the left hepatic artery is then looped and then divided. Here, there will be small twigs to the bile duct and the lymph nodes, which will be taken off with the energy sources. Here we are using, this instrument is Thunderbird, which has the function of sealing as well as dividing. Once the left hepatic artery is divided, the next step is to mobilize the left portal vein. The left portal vein will have a thick fibrous tissue because of its aging and tumor. So once the fibrous tissue is freed and the left portal vein is looped, using a silk tie, the left portal vein is only tied at this point of time because there is no adequate space to divide the left portal vein at this point of time. Once the left portal vein is tied, the inflow to the left lobe of the liver is completely cut off now, and we can see a demarcation in some time. So after that step, then we proceed with cholecystectomy, because the demarcation line will fall on the GB fossa exactly in between. So here you can appreciate the demarcation between the right lobe and left lobe, because left lobe's inflow in the form of left hepatic artery and left portal vein are taken off. So once the demarcation is marked with the energy source, next is to take a complete hilar control, because the demarcation line will have crossover pedicles from the right lobe to left lobe, and we can encounter bleeding during the time of transection from the right lobe, which the inflow is still intact. Once we take a hilar control, in case of an intraduodenal bleeding, we can take the hilar control to stop the bleeding. So this step is a very simple step which enhances and simplifies surgery. So on both sides of the demarcation line, we take vascular slings, tie it to the liver and use it for retraction. as against the open operation where you will be retracting constantly with our hands, laparoscopic surgery using more instrument will lead to more instrument classes and it's going to be cumbersome. So we use two vascular things to retract the liver on either sides. So parenchymal transection is done with the help of instrument called CUSA, which is cavitron ultrasonic irrigator and aspirator. It sucks out the liver tissue, leaves the vascular pedicles intact. This is a while doing parenchymal transection, one of the branches from the middle hepatic vein got teared, and we could see the back bleed from the middle hepatic vein. The middle hepatic vein will be in direct continuity to the inferior vena cava, and even with the inflow control, we can have back bleeds from the middle hepatic vein. So you can see the pulse, that kind of respiratory oscillations in the back bleed because of the communication with the inferior vena cava. So I'd like to just replay this video. So at the time of bleeding, we took a temporary stitch to control the bleed and then did a Pringle maneuver, which is inflow control. And now the bleeding has completely stopped. Once it stopped, we use the time to dissect around the vein and clip it completely, and then we can release the Pringle maneuver. The total Pringle time in this case was 15 minutes, which is acceptable. You can use intermittent Pringle maneuvers because liver is a very good tolerance towards ischemia, and 15 minutes of Pringle and 5 minutes of break will lead to no harm. Now the Pringle is released, the inflow control is released, and the blood flow to the right half of the liver is now re-established. So with CUSA, the continuous dissection is being done, and you can see that it sucks out the liver tissue, only leaving the vascular pedicles, and the vascular pedicle is divided with clips on either side and cutting in between. So as opposed to the open surgery where you go from above downwards, in laparoscopic surgery we divide the liver from below upwards, because here the vision through the camera is from below upwards, and so you can see that it's more like opening the book from the entry to the exit. We will be like opening slowly. Once the parenchymal transection has reached the hilum, so now we are isolating the left hepatic duct, and once left hepatic duct is completely isolated, it will be clipped and divided. So it's clipped with the hemolock, which is the white color clip. Hemolock holds the tissue, and it's better to use hemolock over vascular and biliary structures because metallic clips can slip later. So now the left hepatic duct is divided, and after dividing the left hepatic duct, further parenchymal transection with CUSA is done, and once it reaches the left portal vein, then left portal vein will also be divided. Slowly the parenchymal transection will be extended on to the liver superiorly towards inferior vena cava. So this is the left portal vein, which will be then clipped and divided. So this is a tie which was placed initially, and then to secure it more, we applied additional clips on top of tie. So after dividing the left hepatic duct and left portal vein, and the artery is divided initially only, the hilum is completely free now, and then liver can be easily retracted even further. So with further parenchymal transection using CUSA, we now have reached the left hepatic vein. Since this tumor was predominantly in the segment 4B part, segment 4A was relatively free of tumor, and superiorly we curved towards the left side because it doesn't have any tumor there, and then we could save the middle hepatic vein to the right lobe. So once complete parenchymal transection is proceeded towards the IVC, then that left hepatic vein is looped with a vascular sling. Now liver is hinging to the IVC only with the left hepatic vein, and once it's lifted with a vascular sling, we introduce a vascular stapler, which is a white stapler, to divide the left hepatic vein. And this is the last structure to be divided. So this is a vascular stapler which will be 6 centimeters in length and will have a thickness of 2 mm, and it will completely seal the left hepatic vein. So now the left lobe of the liver is completely divided. We irrigate and look for any bleeding and bile leak. Any bleeding on the cut surface can be easily sealed with bipolar energy devices or argon laser. The left hepatic duct can slough off and can lead to bile leaks later, so it is reinforced with Prolin 40 stitches on top of the clip. So once the hemostasis and biliostasis was ensured, a drain was placed on the cut surface using through the port site only, and then specimen was retrieved. So with the help of this endobag, we will be taking out the specimen. So the surgery lasted 8 hours with a blood loss of around 500 ml. And because of our excellent anesthesia team, the patient could be extubated on table, and he was shifted to surgical post-operative ward. So the patient was transferred to the ward on post-operative day 1. He was started with liquids on post-operative day 1, advanced to normal diet on post-op day 2. It's a protocol to start low molecular weight heparin from post-op day 1 for all patients. And drain was removed on POD 5, and he got discharged on POD 6. Histopathology showed a poorly differentiated adenocarcinoma inconsistent with the CT finding of an intrahepatic cholangiocarcinoma, and the size of the tumor was 7.5 centimeter. It showed grade 3 lineage and resection margins were free. It comes under PT2 stage, which will fall in the stage 2 category. He then received, till this point of time, he has received 4 cycles of adjuvant chemotherapy with capecitabine and oxaliplatin, and he is on regular follow-up. So this image shows the normal open left hepatectomy scar where a reversal incision will be placed, whereas the one on the right side is of the current patient where only port sites are seen, and a small phalansteal incision is used to take out the specimen, which the scar lies here, and it gets tucked in the waistline. So moving on to the second case, and he's a 57-year-old male who had systemic hypertension, bronchial asthma, presented to us with a history of jaundice, loss of appetite and loss of weight with a good performance status. He had a bilirubin of 8.6 with raised biliary enzymes and raised CA19-9, which is the tumor marker for all biliary cancers. CT done showed intrahepatic biliary dilatation in the form of dilated bile ducts within the liver, and there is intrahepatic biliary dilatation is also seen within the head of pancreas. This is a hypodense lesion in the uncinate portion of the pancreas. The CT showed a 2.5 into 3.5 centimeter lesion in the uncinate portion of the pancreas, and the vessels were free. So for Whipple's, as opposed to the hepatectomy, it's a multi-quadrant surgery. So port position, the number of ports are higher, and the patient will be in leg split position, and initially the surgeon will operate from the left side and move on to in between the legs during the second phase of surgery. We retrieve more than 6 lymph nodes. Here the total number of depleted lymph nodes are 13. So why we are discussing about a laparoscopic HPB surgery is because HPB surgeries are generally complex, and even with open surgery it requires a great amount of time and learning and a dedicated team to perform those. So performing the same surgeries by laparoscopic means requires even more commitment and patience. And the first question lies in, is it safe and feasible by doing a laparoscopic HPB surgery? By choosing the patients currently, it's safe and feasible. You should not choose tumors with vascular involvements, tumors with a very vascular or large in size to be manipulated by laparoscopy. So with the proper and optimal patient selection, it's safe and feasible. Oncological outcomes are not different with laparoscopic and open surgeries, even in HPB surgery, and there are papers to show that. Advantages lies in this will pain to the patients. Post-operative quality of life in that initial hospital stay will be better. Short-term outcomes will be better in the form of lesser hospital stay, less pain, small scar, and wound-related complications like wound infections. And they have similar long-term outcomes. For hepatectomies, there are quite a number of RCTs, and meta-analysis of these RCTs also show that laparoscopic surgeries in properly selected patients gave better short-term outcomes with similar long-term outcomes. As far as Whipple surgery is concerned, the data is still evolving, but Whipple's resection has equivalent outcomes. Only the Achilles heel lies in reconstruction, especially pancreatic or jejunal anastomosis, and so the reconstruction in properly selected patients with dilated ducts, the results are similar. So what it takes to perform this complex surgery, anesthesia personal consultants above us and a good nursing team below us is essentially required to perform all these surgeries. And it's not a single man show, you need a dedicated team to all these surgeries. And the confidence or the ability to do these surgeries comes from good open surgery skills and knowledge, and we have to be receptive to embrace new technologies, adapt, learn those things faster, and then implement it, keeping patient at the center of focus and their safety at center of focus. Thank you.
is usually accepted for all procedures for a laparoscope. Still, I still think that it's only for colorectal mets because they are small lesions, which are much less vascularized as compared to HCC. That is where studies have been done to say that maybe it still says that it might become a safe thing.
Yes,
I
ma'am.
think I'm not too sure about the studies you are talking about. I don't think we should take it as a point that lab for HCC can be
I
outside.
can share you the studies. No? Putting studies here is beyond the scope of this discussion with the audience in mind. But selection criteria doesn't involve size of the tumor. It involves the proximity of the tumor to the vasculature. A 2 centimeter lesion doesn't mean it can be removed laparoscopically. If it sits at the hilum, it can't be removed laparoscopically. So good patient selection with no vascular and away from the vessels doesn't preclude a laparoscopic surgery. And the lymphadenectomy margins, everything were similar. What essentially, if you are able to do the same thing which you are going to do in open surgery, it's only a technical skill which you have to adopt it.
I do agree that it is an evolving field for HCC, but we should take it as
For what are the tumors, ma'am? Like we discussed about colorectal mets, we discussed about HCC, we discussed about IHCC. Hilar, we had decided that we will not do. And these are the common tumors of the liver.
Still in open surgery, you can't venture into this techniques of laparoscopy. And unless you have that confidence, you cannot do this. Proper selection of cases is very important, doctor. And the guidelines are still coming up, and as you said, the RCTs have to come, and we have to keep the patient safety with us. Thank you.
Thank you, sir.
That's great. So this is intrasurgical comments, so we can't comment. The Kapias is waiting now.
Yes, definitely it's a very good concept. It's a excellent application. And because of this, we see the energy sources, because that is also mainly plays a role. Because we are assisted 3 decades triple surgery in decades or cases. So that time we were doing.
My comment.
Well, we have to effort and perseverance, gives a lot of determination, dedication and effort to complete the surgery. That's the first thing. And about the rest of it, as you said, proper patient selection and everything is important. Sometimes, especially with laparoscope, the hemoglobin can cause some problems for the tumor aerosol. How much it causes problem in serious non-tumor, it's a gray area. Traditionally, as long as it's evolved, it will be like this. Over a bit of time, there will be some clear guidelines and clear demarcation gradually coming. So initially, because the initial stage is still in gray area.
Thank you,
Thank you,
sir. Thank you, sir.
You can see port site metastasis. But in colorectal mets, in intrahepatic cholangios, generally you don't expect a port site mets. But gallbladder cancer, port site mets is a common entity.
Very good, Jacob.
Thank you.